Very good morning to all of you, and it's my pleasure to be here. And I would like to thank Dr. Neeraj for inviting me to this course on Diploma in Pediatric Allergy and Asthma. So, in the next 30 to 40 minutes, we'll try and talk about childhood asthma, its phenotypes and endotypes. So, as we all know now, that asthma is not a single disease, rather, it is a clinical syndrome. We'll talk about what is meant by a phenotype and what is meant by an endotype, and what are the phenotypes and endotypes of asthma in children. What is the utility of lung function and evaluation of allergen sensitization? Endotyping, when it should be done, and is it really useful for doing an endotyping? And if we do an endotyping, it helps us in doing a personalized therapy for management of childhood asthma, and we'll talk about that. When we talk about asthma or wheezing syndromes, we know that all these syndromes present nearly with the same symptoms. So you will have symptoms of recurring airflow obstruction, bronchial hyperreactivity, and inflammation. Now, what is meant by a phenotype is that it is an observable characteristic such as a clinical presentation, symptoms, triggers, and allergic features. Right? So there might be a phenotype who is allergic to one thing, for example, a dust mite. There might be a phenotype of asthma which is allergic to pollen, but that is basically on a clinical background. Now, these phenotypes can have different endotypes, and an endotype is basically a subtype which is defined by a distinct biological mechanism that links clinical characteristic with a molecular pathway. And an endotype is now being recognized in asthma, and if you recognize an endotype, then you might be able to offer a personalized therapy to this adult or this child. So let's see how do we diagnose a child with asthma, and then we'll take these issues forwards. So asthma is basically diagnosed on symptoms. So you have a child who is coughy, who is wheezy. There are exacerbations. So this child gets flares, which might be in a particular season, which might be virus induced, or which might be because of any other reason. Then you also look at the response to medicine. So we always say that if there's a very good response to bronchodilators or there's a very good response to steroids, then this is possibly a reversible airflow obstruction. It might be an asthma. But we hardly do lung functions. We hardly look at sensitizations. What is the basic reason why this asthma is happening? So, is it actually an allergic asthma or a non allergic type of asthma? And we almost never look at the amount of airway inflammation which is happening. Right? And these are the things which we'll talk about in detail. And simultaneously, we are trying to rule out mimickers of asthma, which is extremely important. Uh, because all that wheezes is not asthma. Now, when we talk about a younger child who is approximately less than 5 years of age, we all know that this is a classical uh, picture from Gina, which talks about a probability based approach. So, on the left hand side, you have a situation where the child is having symptoms for less than 10 days. The child can be coughy, wheezy, heavy breathing, and that usually happens after viral infections. The number of episodes are approximately 2 or 3 a year, and in between, the child is normal. And it says that few will have asthma. Now, as you go on to the middle box, you will find that the duration of episodes increases to more than 10 days. The number of episodes are slightly higher, so more than 3 episodes a year. There can be some episodes which are severe, requiring hospital admissions. There can be night worsening. And in between episodes, the child remains symptomatic. So the child is coughy, the child is wheezy, the child might have heavy breathing, especially in response to exercise. And here it says some will have asthma. Right? So even with this type of a phenotype, not all children will go on to develop asthma in an under 5 situation. Now, on the extreme right, what you find is that all these things remain same as the middle box. There's, but there are two differences. One is that you find that this child has more of exercise-induced problem as well, and the other is that there is a background of allergy. So there might be a history of allergen sensitization. The child might be having an associated atopic dermatitis, food allergy, or there might be a family history of asthma, and that makes asthma much more likely. And most of these children will go on and develop asthma. So these are the phenotypes which you commonly see in under 5 children. Now, to make a diagnosis of asthma, the GINA talks about diagnostic features and it talks about lung functions. So, the diagnostic features are presence of wheeze, presence of shortness of breath, presence of chest tightness and cough, and it describes the criteria on the right. So it says that generally you would have more than one type of respiratory symptom. So the child will not just have cough, but will have cough and wheeze, or cough and shortness of breath, or wheeze and shortness of breath, and so on. So not just one type of symptoms, the symptoms are more variable over time and they vary in intensity. So the child might be symptomatic in few months of the year, and in few months of the year the child is fine. The child might be better in 2022, the child was worse in 2021. There's a variability over time as well, and over year and year as well. The course of the symptoms might be worsening, the course of the symptoms might be improving. There is a nocturnal worsening or on waking up because of the circadian rhythm. There would be triggers like exercise, laughter, allergens, and cold air. And symptoms often worsen or they appear with viral infection. So this is a very characteristic presentation of asthma, which everyone do see in clinical practice. Now, in addition to this, the GINA also talks about documentation with a lung function. So it has to be confirmed, and there has to be a confirmed variable expiratory airflow limitation. So two things need to be met. One, that there is the FEV1 by FVC ratios are low, and in addition the FEV1 is found to be low. So these are the two things which need to be there at some point of time. Now, when that happens, it shows obstruction. But to say that there is a variability or there is a reversibility, you have to document that either the lung functions are reversible, which means that they improve with 400 micrograms of salbutamol, which is given and you repeat it, or you give inhaled corticosteroids and you find that the lung function improves after 4 weeks. In some children, we do an exercise challenge test where the lung function actually is seen to fall. So it is a positive challenge test, and you find that the lung function falls by 10%. So these are the usual tests which are used in clinical practice. Right, so that is what we have talked about. But you also need to remember that this is a very classical presentation of asthma, which we have talked about. But asthma, as we have talked about, is a syndrome, and asthma is also seen as an iceberg. Now, on top of the iceberg, you will find patients who present with classical symptoms, which might be breathlessness, and associated with cough, wheezing, and so on. But but you also find symptoms such as a child presenting just with a recurrent cough or with a recurrent wheeze, or only with a nocturnal cough, only with a persistent cough, or only with an exercise induced cough or wheezing or breathlessness. And we have to remember that these are partial manifestations of asthma, also known as form frustrae manifestations of asthma. Now, since asthma is a very common disease which is found in the society, these partial manifestations of asthma are not rare. And you will find these presentations commonly in your clinical practice. And there would be definitely some children who have airway inflammation, but they are still not symptomatic. There would be children who are sensitive or sensitized to triggers or allergens, but have still not developed inflammation. So let's in brief talk about lung function and allergen testing. So PFTs are usually not done in clinical practice. So the usual reasons which are cited would be that it may not add to the clinical diagnosis. So that is something which I hear day in and day out, that I know this child already has asthma. So if I get a lung function in addition, then how does it add on to the clinical diagnosis? Well, very true. We'll try and look at a few cases to understand what it means. Uh, Many children are not able to perform a spirometry, and that is a usual reason why pediatricians would say कि कर तो पाता नहीं है, फायदा क्या है कराने का. How does it help in follow up if the child is clinically well? So why should I repeat a lung function to see this child is doing well? Where should I get a function from? Do I have a pediatric respiratory or allergy lab in my area, in my city, in my town? Where should I get it from, and who pays? So the cost is also bearing, at least for some sectors of society. Uh, Now, the computer programs, the softwares of the spirometers have significantly improved, and most of these software now come with animations. And these animations could be volume based or flow based, and these help the child to perform the maneuver in a easier manner and make it more fun filled. And we have seen that using these animations can be quite rewarding, and it can be quite entertaining for patients, and you don't need to yell at children and scream at children to just blow and blow. You have to gain trust of the child. Either you do it or your technician does it, but it has to be especially a technician who is trained with and is working with children. Try and teach them all parts of deep inhalation uh, and a forceful exhalation, and then continuing that till you reach to a total lung capacity. And you have to spend time in explaining these. Try and talk to parents as well. Encourage children, give positive reinforcement and reward. And if they refuse to do it, you can ask the parents to perform the maneuver first. You praise the child, reward the child, and even if the child is not willing to do it, you should not get frustrated and irritated. On the other hand, you should still praise them that okay, you've tried it well, and we can do it again in a second appointment. So these are few ways in which spirometries can be done in children. So I'll show you a few of the cases where you will try and understand that there can be different phenotypes of the same disease, and how a lung function can be quite helpful in picking up these phenotypes. So this 14 years old presents to us with exertional breathlessness for the past 2 years. The child isn't coughing, there is no wheezing which has been documented, there is no seasonal variation, there is no family history of asthma. So, what's going on? Is it a cardiac problem? Why is this child having only a breathlessness without any other problems? So, this child undergoes multiple investigations, including an echo, which was normal. So, we also weren't sure what's going on. And we thought that we will try and do an exercise treadmill challenge. But before that, we always would do a baseline spirometry, and this is what happened. So when we did a baseline spirometry of this child, it clearly showed these blue graphs. So this blue graph is the pre-bronchodilator curve. It appears to be scooped and smaller in size, and if you look at the post-bronchodilator curve, then it is significantly larger in size, and the scooping has disappeared. So this child actually has obstruction, and if you look at the values, then the FEV ones are here. Uh, they are like 72%. The FVCs are 78%. And when we look at the change in the FEV1, then you find that the FEV1 changes by or improves by approximately 26%, showing that this child clearly has a reversible airflow obstruction, but this child just presents with breathlessness. So, again, it is a phenotype, it is a clinical presentation or a phenotype of asthma which is seen in clinical practice. Now, this is a 7 years old boy who presents to us with recurrent episodes of cough for the past 2 years. The cough is dry, it is more early morning, during sleep, during exertion, laughing, and crying. Each episodes last for approximately 2 to 3 weeks. It remains well for around 1 to 2 months and then again has a recurrence. So it is never nebulized response to oral salbutamol. It is more during season change, but there are no specific other cough pointers. The anthropometry seems to be normal and the chest is clear. The problem is that this child has been examined by various doctors and wheezing has not been documented. So this child presents only with a cough. There is no wheeze which we could document. Although we can always argue that at the time of presentation the child is not wheezy, but what will you do? So the question is that this child appears to have symptoms of asthma, but again, this child doesn't seem to be wheezing. So, what would you do? Can this still be asthma? So, that is the question which you have. Can you convince parents? Would you like to put this child directly on therapy? Well, most people would like to, have a definitive diagnosis in such situations when the situation is still not absolutely clear. So this child undergoes a lung function testing, and as you can see, there is the pre-bronchodilator curve, which is your blue one, scooped, smaller in size. The red one, which is larger in size, the scooping has somewhat disappeared. If you look at the FEV1 by FVC ratios in the pre-bronchodilator curve, it is something like 54%, which is significantly low. The FEV1 values are something like 49%. The FBCs are 74%. The FEV1 improves by 38%. So again, a reversible airflow obstruction, which is seen. Again, a partial manifestation where only on the basis of clinical presentations you might not be absolutely confident in treating this child. Okay, so now let's look at this girl who is 8 years old, is a known case of asthma, was on inhaled corticosteroids, tapered, was well. So the steroids were tapered and stopped after a period of around a year, and now she comes in follow up after 3 months, and she is clinically well. So again, the question is that would you actually do a lung function and follow up to see whether this child has remained well? Now this is the lung function of this girl, and as you see that again the blue curve, the pre-bronchodilator curve, the red curve, the post-bronchodilator curve, the significant scooping which is there, which has disappeared. Now if you look at the FEV ones, then the Z scores are something like 1.73, with the cutoff is -2, so it does not fall into that category still. But if you look at the curves and if you look at the post bronchodilator response, then the FEV1 improves by 27%. And it clearly shows that this child actually was developing obstruction and reversibility, but was still asymptomatic. So, that is the utility of doing lung function in follow up after you've stopped inhaled corticosteroids, because many of these children will be getting developing inflammation, will be developing obstruction. At this point of time, they may not be symptomatic, but definitely they will get symptomatic in the course of time. So, if you look at the classification of asthma severity in children, then most of this data which comes uh, is obviously old, because this question now is hardly discussed. And the world is absolutely clear that if you add lung function to classification of asthma severity, a few of your patients, approximately 20-25% of your patients, uh, will have a change in the classification. And this is what is depicted in these cohorts. Now, if you do lung function in addition to your clinical testing, then a lot of patients which you feel that they have mild persistent asthma will go on and shift their category. So if you look at symptoms only in this cohort, then this is the clear bar is the mild intermittent. The light gray part is the mild persistent, and the dark gray part is the moderate to severe persistent asthma. Now, when you add lung function to it, then you can see that the number of patients who are actually having a moderate or severe persistent asthma would be higher because they are reclassified based on the obstruction on lung function. And similarly, there would be more patients in the mild persistent group as well. So, what it basically implies is that we tend to underestimate the amount of obstruction which this child is having, and adding a lung function to your clinical diagnosis, even during follow up, is going to help you classify and manage your patients in a better way. Now, that's about an older child, but you might be having young children as well. So, if you have a 3 years old who presents to you just with a chronic cough with no wheeze, then what should I do? Do I manage this child clinically only? Well, you can do that, nothing wrong with that, but can you do something better? A 5 years old has a suspected asthma. Uh, Now fails a spirometry. So you try to do a spirometry, but the child fails to do a perform a spirometry. And as we know that in the preschool age group, the failure rates are quite high, something like 40-50%. And I was 6 years old with suspected asthma, but has a normal spirometry, then what would I do? Right. So let's look at these cases and let's see what we can do about them. So we have a new tool which is now available, and I would not say really new because this tool we have been using it at least for the last 9 years now. So we started this in 2012. So this is what is known as an impulse oscillometer. The impulse oscillometer has a loudspeaker which produces noise, and this noise actually passes through and is going to come this way, and it gets superimposed on the breathing of this child. So the child holds on to the mouthpiece and breathes slowly in a tidal manner. So there is no blowing in this. The child breathes normally. Now, what the pneumotac actually measures is a combination of the noise which is coming from the loudspeaker, which gets superimposed on the breathing of this child, and that is what this pneumotac actually measures and what is read by the computer. Now, these sound waves, as they get superimposed on the breathing of this child, have different characteristics, right? So you have sound waves of different frequencies, and uh, the sound waves can uh, the sound waves which are of lower frequency can actually travel deeper into the airways. On the other hand, the sound waves of higher frequency uh, would remain only in the larger airways. And this difference actually helps us in judging obstruction in the smaller and in the larger airways. So, that is the basic principle of an impulse oscillometry. So this is what you get, and these values are absolutely different from what you actually get in a spirometry. So you get resistance, and what you get is also reactance, and you get it across various frequencies. So you get it from 5 hertz, 10 hertz, 20, 30, and 40 hertz. and you again get reactants on various frequencies, and together the resistance and reactance is what is known as impedance. Now, if your child has airway obstruction, then what is found is that at lower frequencies, the resistance is significantly higher compared to higher frequencies, and that is what happens classically in a peripheral airflow obstruction. And similarly, the reactance also reduces. Now, we did a thesis of our first DNB student where we tried to look at uh, a comparison between the diagnostic yield of a spirometry and oscillometry. So, for the first time, we did it in a research mode, because prior to that, what we were doing was that in older children, we tried to do spirometries. If they failed, we tried to do oscillometries, but we weren't doing both. And in younger children, we were predominantly doing oscillometries. Now, in this research mode, we had to do both, right? And I'll tell you what the results were. So we took approximately 100 patients, and we have done after the thesis even more. So we might have done approximately 400, 500 patients as of now. Uh, they were a combination of suspected and known asthma, and again a combination of controlled, partially controlled, and poorly controlled patients. Though what we found that if you do an oscillometry, you could pick up approximately 60 to 66% of patients. The yield of spirometry was low. Uh, there's a group of patients who have obstruction on both. There's a group of patients who has obstruction only on oscillometry. There's a group of patients who have obstruction only on spirometry. And there can be a group of patients who show a normal lung function. Uh, but if you combine these modalities, you can pick up approximately 72% of patients. And that actually led us to the realization that, the oscillometry and the spirometry actually measures different things, possibly the larger and the smaller airways. And now we actually combine these modalities, and because we use a care fusion equipment which has both into one machine, the job is not more difficult. It hardly takes a few seconds or minutes more, but definitely it makes the lung function much more useful. So this coming back to these cases, so this 3 years old with chronic cough has no wheeze and has got multiple antibiotics, has got bronchodilator, has got nebulization, but the parents aren't quite happy. So what do you do? So you do a lung function, you find that the R5 values are raised. You repeat a lung function after a bronchodilator, and you see that the R5 have significantly improved, and the AX value, which is the area under the curve, has also significantly improved. So that signifies that there is obstruction and there is reversibility. It is easier to convince yourself, it is easier to convince parents to take an inhaler therapy and to manage this child. Now, similarly, this is a 5 years old where the spirometry failed. We did an oscillometry, and again, the oscillometry shows obstruction. Uh, so you can see the comparison between the R5, which is raised, as compared to the R20, which is seen in the graph as well. Now, this is the third child, 6 years old. Frequent symptoms, nebulization, but lung functions are normal. So, what should I do? Right. So, the spirometries are absolutely normal. There is no reversibility as well. Now, if you do a lung function, you find that the R5s are raised and there is significant reversibility as well. So, there's a group of patients who actually have obstruction only on a oscillometry, but not on a spirometry, and that is what is classified as a small airway disease. So, these are the airways which are there in the lung. So you can have large and medium airways which are more than 2 millimeter in size, and then you have airways which are less than 2 millimeter in size and which are called as small airways. Now, There has been a clinical pattern recognition of small airway asthma phenotype where you actually find that they're not very well controlled. So you find that if you use an asthma control questionnaire, the scores are high. They might be having daytime symptoms, nighttime symptoms, use of bronchodilators, use of steroids, but actually their FEV1s are actually normal. And that led to more of research, and people realized that the FEV1s are normal, but actually the small airways are involved, which we weren't actually picking up. And people have used different modalities to look at obstruction to the smaller airways. People have used FEFs 25 to 75, which we understand is not a very robust criteria. People have used impulse oscillometry, as we have talked about. People have also used CT scans, which are definitely not worth because of the radiation which is associated. Oops, sorry. Right. So this is a data which looks at small airway disease, and looks at the various steps at which small airway obstruction is found. And if you look at the GINA 1 to GINA 5, you will realize that as you go across to higher GINA steps or more severe form of disease, then the amount of small airway obstruction which you find is significantly more. So somewhere ranging from 40% to 80%. So it definitely increases. There is obviously a variability which you find in using the different modalities. Uh, so using FEFs versus plethysmography versus oscillometries and multiple breath washouts. So that these are different ways people have tried and quantified small airway disease. So this is a combined data of children and adults. And as I said, some people have also used HRCTs, which we don't prefer in the pediatric age group. So, small airway dysfunction in childhood is again a phenotype which is seen, um, and it is believed that 25 to 40% of children with asthma will have small airway disease. Uh, Children with control asthma, it has been seen, who have increased peripheral airway obstruction, they're at increased risk of losing asthma control. So we do see a few patients where they are well. The spirometries are normal, but if I do an IOS or an pulse oscillometry, the values are significantly high. And that has now taught us to wait on that particular dose, not reduce the dose, give them some time to settle down. Because if you do that at that particular point of time, the chances of having an exacerbations are significantly high. It might be a quite a reliable and non-invasive method to assess control in children, and that is we also agree with that, and we realize that. And an improvement in the AX is considered to be a very important marker of disease in follow. So we talked about these questions that the child seems to have asthma. Why should I do a lung function? It may not add to the clinical diagnosis. Well, there would be clinically ambiguous situations or asthma mimics which needs to be defined. There would be partial presentation of asthmas like a cough variant asthma or an exercise induced asthma where you need a lung function. There would be definite patients who are having a poor control despite therapy, and in such situations, lung function is mandatory. And there's a large group of patients and parents who want a diagnosis with certainty. And doing a lung function in such situations actually sorts out these patients. Uh, it becomes quite easier to convince parents and patients to take inhaler therapy, and also makes them understand that it has to be taken in long term, and it is a preventive or a controller therapy. So there are many reasons why, as I said, lung function will help you in diagnosis. We are not trying to say that you cannot treat a child with asthma without doing a lung function. No, that is not the message. But as an allergist group or a pulmonologist group, uh, you will be referred, and you will find more cases who are not run of the mill patients. And in these patients, you need to sort out these patients. Lung functions are extremely important. There's also an alibi that many children not able to perform well. Good coachings using animations is something which can be done, and the availability of impulse oscillometry is a big boon to us, because we can do lung functions now in children somewhere like 3 years and above. Where should I get it done from? Well, there's an increasing availability of pediatric PFT labs. And it is important to understand that a good quality lung function is extremely important. If poorly done, then it's not going to help you in any way. How does it help in follow up if the child is clinically well? We have answered this question with the help of a few cases. So it helps to assess the degree of obstruction and in defining control. And as I shown you the Canadian data, uh, which tells us that there can be a discrepancy between the level of obstruction and the clinical symptoms. And if you use a lung function in follow up, you will realize that a lot of patients appear to be clinically well, but they are still having significant amount of obstruction in their airways. So lung function at when it should be done, well, the ideal practice says always in all patients, but what we understand in our milieu with our resources, that you should do it at the start of treatment, if possible. You defer it in children who presents with an acute flare-up. An interval spirometry can be done. uh, if you actually need it, then you can repeat it if there's a diagnostic dilemma. Uh, Assess control of on therapy, so you can do it in follow up, especially in your moderate to severe patients, which you will have definitely more as you belong to the allergy group. Oscillometry, to summarize here, use it in children who are less than 6 years of age who have suspected asthma, older children if they are unable to perform a spirometry, or in older children where you find a discrepancy between symptoms and lung functions. So, a child is symptomatic, but the spirometry is normal. So, what's going on? They can be having a small airway disease. And it also helps in assessment of control, as we have talked about. So, briefly about allergen sensitization and allergy testing, and again, it will help us to understand that there are different phenotypes here as well. Well, allergen testing, when is it recommended? So, if you look at the asthma and the recurrent wheezing, that all the ACI guidelines says that all children with persistent asthma should get an allergy testing, and we agree with that. If you have young children who present to you with wheezing, which are unrelated to viral infections, then you should consider doing an allergy testing in this age group. Now again, the same question creeps up that I have already established that this child has asthma. I have done a lung function. Then what's the fun of knowing what allergen is implicated? Because finally the treatment is the same. Well, there are many reasons why, and let's understand. So, a targeted avoidance of relevant exposure is shown to improve outcomes, and they are definitely more effective than untargeted avoidance. So, telling them that you avoid all these 100 things is sometimes difficult. But if you tell them that you need to avoid these two or three things which are actually implicated in your asthma, that seems to be quite easier and practical. It helps you to decide about the seasonal pattern, and treatment can be initiated in a timely manner. So, you can have a pollen induced problem. You can have a pollen induced rhinitis, even sometimes a pollen induced asthma. And you can put them on therapy before the season starts and end it after the season ends. And definitely, there's a group of children who require allergen immunotherapy as well. But if you do not know what allergen is implicated, then how would you do allergen immunotherapy? Well, the allergy testing can be done with a skin prick test, and you can have an immunocap, which is your blood allergy testing. And I'll not go into a lot of details because this must have been discussed in your course at multiple point of time. Uh, Both tests seems to be good, but the skin prick test actually deals with and picks up the IgE, which is bound to mast cells. On the other hand, if you're using an immunocap, then or a blood allergy test, then it only captures the serum IgE, which is actually not bound to the mast cells, and hence the skin prick tests are considered to be the gold standard at all places. But as of now, even the blood allergy testing with immunocap is definitely a very sensitive and a specific way to diagnose the concerned allergens. So the allergens could be indoor allergens like dust mite, dander, cockroach, and molds. You can have outdoor allergens like relevant pollens, and they can be food and insects as well. But these are not of concern for children with rhinitis and asthma usually. Uh, you can choose a panel. This is something which we do at our hospital and clinic. So we use a very limited panel of indoor allergens and outdoor allergens, just one or two fungi which are important, and few pollens. We try and limit the pollens which we want to test, which are uh, present, which are relevant to Delhi and NCR, and also they are significantly allergenic to have a clinical meaning. There is no sense of testing, 100 allergens, most of which are not really allergenic, and it does not help to make a diagnosis. So this is how anyone would do it. You mark these allergens, and you put a drop of these allergens which are available to you, and then with the lancet you start with the saline, go in this direction, and gradually move on. You gradually move on this direction and you end up with your histamine. These are few examples. So children, like this child was sensitized highly to dust mite, and this is a positive control. So this child was exclusively sensitized to Alternaria alternata, and this child was polysensitized. So dust mite, presence of cockroach, and presence of amaranthus. So again, these are phenotypes which you find in clinical practice. So a pollen-induced disease versus a mold-induced versus a dust mite-induced versus a dander-induced. Do they behave differently? Well, there are certain questions which we still do not know at this moment, but there are a lot of clinical phenotypes which we find in clinical practice. Uh, and gradually, with better diagnostic modalities, our understanding is gradually improving. So treatment of allergic disorders, it involves the patient education, which is always indicated, pharmacotherapy, which is obviously which needs to be started. It is effective and easily administered. There are situations when allergen avoidance needs to be done, and there would be occasional children who where you will consider doing an allergen immunotherapy as well. So there are many phenotypes of asthma which have been defined. We have talked about most of these things. So they can be children who present with recurrent viral wheeze, but they can be children who start almost at the same time, and they go on. They might be having a mild allergic asthma versus a severe asthma with multiple allergies. Uh, they can be severe non-allergic neutrophilic asthma, which we are now learning about it, and they can be a late onset asthma, which is seen somewhere from school age, and there are different trajectories which have been defined in different cohorts. So let's talk about endotypes now after phenotypes. So these are the usual phenotypes which have been described across the world. So you can have an eosinophilic asthma. where the predominant type of inflammation is eosinophilic, uh, they can be eosinophilic asthma again could be allergic. So, an allergic eosinophilic asthma versus a non allergic eosinophilic asthma. So, eosinophilic inflammation, but you still don't find any specific sensitizations. Then you can have an asthma which is neutrophilic, so predominantly neutrophils which are there in the reaction. You can have a mixed granulocytic asthma, so you find eosinophils and neutrophils both, and you can have a polygranulocytic, so which means that the inflammation seems to be there, but again the eosinophils and the neutrophils seems to be significantly low. So these are the different endotypes which we are learning about. They're more properly described in the adult population and not very well defined in the children population, principally because the number of children who actually have a severe asthma and undergo an endotyping is significantly less. So, what we are trying to do here is to look at the underlying inflammation. And again, the key question here is that if you're trying to look at the airway inflammation, does it again add on to your asthma diagnosis? Does it help you to define control? And does it help you to treat the child? So, if I say that a child has an eosinophilic asthma and improves with 100 micrograms of budesonide versus a child with neutrophilic asthma who also improves with 100 micrograms of budesonide, then what's the fun in knowing whether it is allergic in eosinophilic inflammation or neutrophilic inflammation? Does it actually matter to you or to the patient? Well, no. Now, that is what exactly we are trying to say, that does it make sense to assess the airway inflammation, right? And does it add on to any of these things? Well, if it does not, then it doesn't make sense. But if it does, then definitely it needs to be done. Now, what we understand is that when you are landing onto the step 5 of GINA, where the child is still not controlled with high dose of inhaled corticosteroid, LAVA with montelukast, and now also tiotropium. This is a point of time when we need to consider this child as a severe asthma, and this child needs to be evaluated further. Right. Now, when we look at a difficult asthma algorithm, and this is again from the GINA Guide on Management of Severe Asthma, you try and confirm your diagnosis. Is it actually asthma or is it something else? Is it not a bronchiectasis or a ciliary dyskinesia or a cystic fibrosis or an ABP and so on? The step 2 is to look for factors which are contributing to symptoms, the exacerbations, the poor quality of life. And obviously, at any point of time during your treatment, you are trying to again look at asthma education, the technique, the adherence, the comorbid conditions, and you want to step up. Now, these things should be done at all stages, and no one should actually omit these because these are the most important thing. Now, you have done that, and now you have followed this child for 3 to 6 months. So, as you realize that a child walks into your clinic with severe asthma, but still for the next 3 to 6 months, you're not trying to jump to the other steps and trying to follow up this child to see how this child is behaving. And actually, you have dealt with these factors which are extremely important. So at the end of around 3 to 6 months, you still realize that this child, after doing all these things, remains uncontrolled, and you label this child as a severe asthma. Now, then actually comes the role of assessing what type of inflammation is there. And to assess the type of inflammation, we try and do an FeNO, which is your exhaled nitric oxide. You can consider getting blood and sputum eosinophils, consider a skin prick test or an immunocap if it has still not been done. And at this point of time, it is always better to refer a child to a specialist. Now, we are trying to assess airway inflammation. So, what tools do we have? Well, these are the tools which are available. The red ones are definitely better, but they are definitely more invasive and may not be possible at all centers. So, doing bronchoalveolar lavage and taking endobronchial biopsies is a very gold standard way. Then doing a sputum analysis. Well, this is not as easy as what it looks like. So doing sputum eosinophils, doing an FeNO, doing an exhale breath concentrate, and doing volatile organic acid. So these are the ways which have been cited, but most of these are still not standardized, still not available into clinical practice. Uh, and the only tool which we actually have available in the clinical setup is an FeNO, and we'll talk about the FeNO. So, normal epithelial cells do not release significant amount of nitric oxide, but when there is eosinophilic inflammation, then there is significant amount of nitric oxide which is produced, and that is the basic principle of an FeNO. So, the advantages are that it is a non-invasive test. You can repeat it whenever you want to. It can be performed in children who are as young as 4 years of age. It is relatively easy to do, even in children who have severe airflow obstruction. Right. So the ease of doing the test is a big advantage. But does it help? So this is a data which comes up from a meta-analysis which talks about uh, the the utility of pheno in asthma diagnosis. So it says that the sensitivity range from approximately 43 to 88%, and the specificity from 60 to 92%. And again, the positive and the negative predictive values are quite variable. So what they interpret it is that approximately 1 in 5 patients with a positive pheno doesn't have asthma. So they can be false positive, and approximately 1 in 5 with a negative pheno still has asthma. So the utility of pheno in diagnosis of asthma is not there, and most people don't use it for this purpose at the moment. Uh, then the other use of pheno is to tailor your treatment. So a child comes to you in your office, and you try and do a lung function, but you also do a pheno, and based on the pheno you try and decide what you are going to do about this child, right? Whether you want to increase your treatment, whether you want to keep the treatment as same, or whether you want to reduce it. So what people have seen is that if you actually tweak the treatment based on the pheno, then the number of exacerbations definitely go lower. But the number of children receiving oral steroids were also lower, but there are no significant differences in FEV1s, in symptom scores, or inhaled corticosteroids. Uh, and the other part of the problem is that it has been seen that the group which where the pheno was done, a higher amount of inhaled corticosteroids were used. So, what it found was that it definitely reduces exacerbation, but it does not help you in changing day to day symptoms, asthma control, lung functions, and inhaled corticosteroid doses. It can be helpful to guide asthma therapy in a select few patients, and it cannot be recommended universally for all patients with asthma. And we still need more trials, more data, that when actually pheno should be used, at which point of the algorithm it should be used. There has been, a lot of talk about that. What tool should you use? Is your pheno enough, or you should go on with different other tools? So what has been found is that the eosinophilic airway inflammation is associated with increased corticosteroid responsiveness in asthma, and as I said, you have direct and indirect methods. So the direct methods are BAL, endobronchial biopsy, and induced sputum. It is definitely invasive and more laborious. You have minimally invasive markers like pheno, blood eosinophilia serum, IgE. Now, the problem is that most of these data is from adults, and we do not have a lot of data from children. So, in this meta analysis, as you can see, that the studies in children were quite low, and most of the data actually comes from adults. Uh, and what this a systematic review and meta-analysis actually analyzed was that Just using pheno or blood eosinophil or serum Ig as a single surrogate test for airway inflammation and asthma is something which is not something which is quite good. Try and combine markers with other clinical features in a prediction model, and it is likely to improve your diagnostic accuracy compared with single markers. But this has not been significantly or sufficiently investigated. And what also has been found that the sputum phenotypes may not be stable. So you can have a Th2 driven asthma. The child was eosinophilic, got inhaled corticosteroid, now become posse inflammatory. You can have the child can become more eosinophilic if the adherence fails, or if the child is exposure to a large allergen load, the child become neutrophilic if the child is exposed to a viral infection. And sputum results may not correlate with the FeNO levels. So the usual things which people would do in such situations is to look at symptoms, do a lung function, do an FeNO, do a bronchoscopy and endobronchial biopsy. So this is the pediatric protocol from Brompton, which is universally recognized now. Um, uh, People do a 24-hour esophageal pH as well to look at GERD, and try and give an injection of triamcinolone 80 milligram intramuscularly, because the response to corticosteroids is something which is a surrogate marker for eosinophilic inflammation. After 4 weeks, they try and repeat all the investigations except the invasive one. So usually the bronchoscopy is something which is not done. So you try and look at whether it is an eosinophilic phenotype or a non-eosinophilic phenotype, and I've talked about in the last few slides that sometimes actually phenotyping is not that simple as it appears in the algorithm, because you do not have extremely good non-invasive test available to you, and multiple tests should be combined. So these are the non-biological step-ups which are available. So you can use smart inhalers, which means you can use budesonide formoterol combination as a reliever and preventer. You can try the child on high-dose inhaled corticosteroids for a short time of 3 to 6 months. You can consider tiotropium and consider GERD, bronchopulmonary aspergillosis, rhinosinusitis, and atopic dermatitis, which can be comorbid or mimics. In the non-eosinophilic phenotypes, again, look at the basics like the differential diagnosis, the technique, the adherence, the comorbid conditions. Try and consider tiotropium and macrolides. Consider low-dose oral corticosteroids. Consider getting a CT chest, a bronchoscopy, a sputum induction. And these children might be candidates of bronchial thermoplasty, but we don't have data for that as of now. The biologicals which we have available to us are omalizumab, which is anti-IgE. The FDA approval is more than 6 years of age. Then you have mepolizumab available with the name of Nucala, which is an anti-IL-5, which you can use in more than 6 years now. That is the European Medical Association approval. Then you have resilimumab, benralizumab, and dupilumab, which are hardly used in clinical practice, at least in the pediatric age group. Dupilumab is an excellent drug which has been shown to be of benefit in children who have very severe atopic dermatitis as well. So, if you have an eosinophilic phenotype, consider doing a step up. So, the step up at 6A would be biological treatments if they are available and affordable. But there can be situations when biologicals are not affordable, and I would say that these situations are not uncommon. Because most patients of ours do not get any reimbursement, and spending out of the pocket for biologicals is something which is not easy. Uh, in these situations, you have options of high dose inhaled corticosteroid, adding LAMA, which is your tiotropium, LTRAs, and considering low dose oral corticosteroids. Step 6B is to use biologicals. Well, you can consider using omalizumab. You can consider using mepolizumab, especially in children who have eosinophilic asthma. And the other option is to use dupilumab, where it is eosinophilic, and especially if they have an associated atopic dermatitis. Right now, with that, we end with the endotypes, and let's finally conclude that most children with asthma can be managed clinically. Lung functions are useful in confirming the diagnosis and assessment of control. We know that. Oscillometry is a useful modality in young children. Allergy testing is useful for assessing sensitization and selecting patients for immunotherapy. And the endotypes need to be evaluated only if the phenotype seems to be severe. Doing endotyping in all patients is something which is not needed, not required as of now. Thank you very much, and I will again thank my colleague Dr. Neeraj for inviting me here to this program.